Welcome dear students, I am Dr. Pratyusha and in this video let us learn about the other types of acute otitis media apart from acute suppurative otitis media. About ASOM you have already learnt in detail and now let us see a few other varieties that you need to have an idea about. Acute otitis media. First in this list is the condition called as recurrent acute otitis media. The name itself is suggesting the condition, but you need to have a clearer picture. In whom is this recurrent acute otitis media seen? In the age group of 6 months to 6 years. This is the age group where we find the complaint, the problem of recurrent episodes of acute otitis media. What is the exact definition? What do you mean by recurrent? 4 or more episodes per year. 4 or more episodes of acute otitis media per 1 year, we call it as recurrent acute otitis media. Now, why does this occur? What are the predisposing factors we need to know? It usually follows an acute upper respiratory tract infection. It begins as an upper respiratory tract infection and then you will see the child presenting with otitis media. It can be associated with recurrent sinusitis. Recurrent sinusitis leading to recurrent middle ear infection. There could be some velopharyngeal insufficiency. This will affect the eustachian tube function and lead to middle ear infective episodes. What else could be the cause? Adenoid hypertrophy. Adenoid hypertrophy is also common in the pediatric age group, isn't it? When there is adenoid hypertrophy also, there could be episodes of middle ear infection. The sister condition of adenoid hypertrophy is tonsillitis. Allergy. Repeated manifestations of allergy, repeated episodes of allergy. There is always engorgement, edematous condition in the nose and nasopharynx, and that will eventually affect the eustachian tube function leading to acute otitis media, recurrent episodes. Immunodeficiency. Immunodeficient kids are susceptible to all sorts of infections, including otitis media. Most important reason, most specific reason I can say is feeding the babies in supine position. Some mothers do not know how to hold the baby while feeding. And see, this is seen in the age group of 6 months to 6 years. So, a part of it is well during the lactation and a part of it is still when the baby is dependent on the mother for feeding. So, if the baby is held in supine position without proper propping up of the head, that can also lead to acute otitis media. Why and how? Because the eustachian tube in children, it is short and wide, it is more horizontal, there is no angulation at the isthmus. All these factors we have discussed in eustachian tube in children, isn't it? They predispose for the reflux of nasopharyngeal secretions into the middle ear, eventually causing infection. So, proper positioning of the baby is very important. Feeding the baby in supine position. I hope you have understood why and how. This I can say is the most characteristic predisposing factor. So because of one or more of the above reasons, the child is in a state of recurrent acute otitis media. Now, how do we treat this? The pathogenesis, clinical features, they are all same as any other acute otitis media. Okay. In treatment, the most important step is to eliminate the cause. You have to do a thorough ENT examination and look for all the above features. You have to look if there is any problem with the sinus ostia. You have to look if there is some adenoid hypertrophy, tonsil inflammation, velopharyngeal insufficiency, or some other soft palate problem, or you have to look if there is any allergic history in the child, and you should also counsel the mother about proper positioning of the baby during feeding. So try to find out the cause. Why is the child landing up in repeated episodes of ear infection? How do we eliminate the cause? By doing certain surgeries, surgical prophylaxis. In which conditions will we go for surgical prophylaxis? If there is adenoid hypertrophy, we can go for adenoidectomy. If there is repeated tonsillitis, we can go for tonsillectomy. Apart from these two, we can also do something called as placing a tympanostomy tube. Okay, tympanostomy tube, a grommet can be inserted. And what is the indication for tympanostomy tube insertion? If there are at least 4 episodes in 6 months or 6 episodes in 1 year. You will observe the child for a period of 6 months to 1 year, and if there are at least 4 episodes in 6 months or 6 episodes in 1 year, that is an indication for you to put a tympanostomy tube. Apart from that, there is some role for antibiotic prophylaxis. It's not just antibiotic prophylaxis, it is antibiotic treatment also. Every time the child presents to you with acute otitis media, you will definitely give antibiotics to resolve that infection. And every time the child presents to you, you are prescribing antibiotics, and sometimes we prescribe antibiotics as prophylaxis also for a period of about 3 months to 6 months. But this continuous use of antibiotics is highly discouraged to prevent antibiotic resistance, to prevent the inadvertent use of antibiotics. So it can be tried initially, but the better way of dealing with the situation would be to find out the cause and eliminate the cause rather than continuously prescribing antibiotics. Surgical prophylaxis is good, and if there is any other cause, that has to be eliminated, evaluated and eliminated. So this is all about recurrent acute otitis media. It's a simple condition, but please be alert when a child is repeatedly coming to you. Otherwise, sometimes parents might change the doctor after 2 or 3 episodes. It's important that you ask for a history of the number of previous such episodes and understand that it is a case of recurrent acute otitis media. This is all about this. Let us move on to the next condition, and that is acute necrotizing otitis media. Acute necrotizing otitis media. The name is suggesting that it is something bad, necrotizing, okay, a bad condition, but you should know a little more in detail about it. The number one feature that you must know is this is also seen in children. In children who are suffering from acute exanthematous fevers such as measles, or influenza, or scarlet fever, in all these kids, suddenly there can be an episode of middle ear infection. And the importance of this is there will be rapid destruction It will not proceed like a normal otitis media. There is a very rapid destruction of tympanic membrane with the annulus. Even the outer ring, the resistive rim is also destroyed. The tympanic membrane with the annulus, mucosa of promontory, ossicles and mastoid air cells. All these structures are very rapidly destroyed. And what is the causative organism? It is beta hemolytic streptococcus. This beta hemolytic streptococcus, in the background of fevers such as measles or influenza, will set out and cause a rapid destruction of the ear structures, middle ear structures to be precise, and this results in acute necrotizing otitis media. The patient will present to you with profuse otorrhea. We are focusing on the fever and suddenly there is this complaint of acute ear discharge, profuse ear discharge, and your attention should go into suspecting acute necrotizing otitis media. Why is it important? Because it's a very rapid process. It requires your immediate attention and radical treatment without any delay. And this profuse otorrhea can later on progress, it can heal by fibrosis, or another bad possibility is it can also result in the formation of secondary acquired cholesteatoma. Repeat. Or another bad possibility is it can also result in secondary acquired cholesteatoma. And how do we treat this condition? Immediate antibacterial therapy, because it is caused by beta hemolytic streptococcus, a bacteria. So antibacterial treatment is of paramount importance for a period of 7 to 10 days. High dose antibiotics have to be prescribed, and if at all it doesn't resolve, we have to go for a surgery called as cortical mastoidectomy. This is all about acute necrotizing otitis media. Now see, when a question like this is asked in exams, all of you will write about necrosis. You will write that it's a rapidly destructive procedure, it destroys the entire middle ear and all that. But what will fetch you marks is these 2 points. You have to write that it is seen in children suffering from measles or influenza, and you must also remember to write that it is caused by beta hemolytic streptococcus. This middle point you will anyhow write, treatment you will anyhow write. These 2 are important. It is seen in children and it is caused by beta hemolytic streptococcus. And of course, cortical mastoidectomy also. This is all about acute necrotizing otitis media. Let us move on to the next condition, a very interesting condition, that is Aero Otitis Media or otitic barotrauma. I'm sure all of y'all must have seen at least one case of this if you are a frequent air traveler. This is a condition seen outside the hospital setting. It is slightly conceptual, so pay attention. Now, we know that one of the functions of the eustachian tube is to maintain equal pressure on both sides of the tympanic membrane. On one side we have the external environment and on the other side we have the middle ear. And now it is the role of the eustachian tube to maintain equal pressure on both these sides of the tympanic membrane. Yes, that is the function of eustachian tube. A failure to do this function will result in Aero Otitis Media or otitic barotrauma. Let us see what exactly is happening. Now this condition usually occurs during a rapid descent in air travel, during underwater diving, and during compression in a pressure chamber. Out of all these, this is the most common and most important. So let us focus our entire discussion on rapid descent in air travel, and you will eventually understand the other two also, not a problem. But let's keep our discussion central to air travel. What exactly is happening? Let us understand the mechanism of air travel. What exactly is happening? Let's begin with basic physics. As altitude increases, atmospheric pressure decreases. That is the basic thumb rule that you must remember, okay? As we ascend into higher and higher altitude, higher height, the atmospheric pressure drops, okay? Clear? Now, during a flight travel, in the initial ascent, the ambient pressure is decreasing. As we are going higher and higher up, the ambient pressure is decreasing. Now, the external environment, on one side of the tympanic membrane, the pressure is dropping. The middle ear pressure is relatively high. So, what should the eustachian tube do? It should reduce the middle ear pressure. Now, the eustachian tube can only influence the middle ear. It cannot influence the external environment, right? So, the middle ear pressure is high. The eustachian tube will try to reduce this pressure, and that is very easy. It's just a passive process. It will allow the air to regress, to escape into the nasopharynx. Okay. During ascent, what's happening? Atmospheric pressure is dropping. Middle ear pressure is high. So, what will the eustachian tube do? It will allow escape of air from middle ear into the nasopharynx. This is an easy and passive process, no problem, okay. Then ascent is over, mid-air also this will continue, and then comes the phase of descent. During descent, what is happening? As we are coming down, the atmospheric pressure increases. Yes? Now, the external atmospheric pressure on the outside of tympanic membrane, this is high, and the middle ear pressure is relatively low. Yes? Middle ear pressure is relatively low. A negative pressure is created inside the middle ear. Now, what can we do to increase the pressure? We have to draw air from the nasopharynx into the middle ear. But this is an active process because the opening of the eustachian tube in the nasopharyngeal end is always closed. It opens only once in a while during swallowing, during yawning, during Valsalva, during such specific maneuvers, and once in every 15 to 20 minutes it opens and closes again. Basically, it's always in a closed state. Once in a while it opens. So now we have to make sure that this opening of the eustachian tube is kept wide open and air is allowed from the nasopharynx into the middle ear to balance the pressure on both sides of the tympanic membrane. and this is not happening. That is the reason there is imbalance of pressure and pain. Let me explain what's happening. So here, what is the ET doing? It should, now air has to enter middle ear from nasopharynx, and for that ET has to be opened actively. Eustachian tube has to be opened actively. And how does this occur? By yawning, swallowing, or Valsalva, just as we have discussed. But sometimes these processes do not occur naturally, and when the difference in pressure, the atmospheric pressure and the middle ear pressure, when the difference crosses a critical point of 90 mmHg, 90 mm pressure, when atmospheric pressure is more than the middle ear pressure by 90 mm, this is the critical pressure. If the difference is more than 90 mm of mercury, it results in a dangerous condition called as blocking or locking of eustachian tube. When the eustachian tube gets locked, further air cannot enter into the middle ear. As such, middle ear is in negative pressure. We are trying to draw air, and now the eustachian tube is also locked. What do I mean by locked? The soft tissues that are present in the nasopharyngeal end, they are forced into the lumen. It is locked, and the pressure becomes further and further negative, and that loop continues. The difference between the middle ear and the ambient atmospheric pressure outside, the difference keeps on increasing, and there is more and more negative pressure, and that will lead to all the problems in Aero Otitis Media or barotrauma. Why will this locking occur in some people and sometimes? The predisposing factor is if the eustachian tube is edematous because of some pre-existing problem, edematous eustachian tube, in a pressure even less than 90 mmHg, locking can occur. Locking can occur at even lesser pressure. So once locking has occurred and there develops negative pressure in the middle ear, let us see the turn of events. Now there is negative pressure in middle ear. We are trying to sort it out, but the eustachian tube is locked. What will this result in? There will be retraction of tympanic membrane. Negative pressure has a sucking force. It will cause retraction of tympanic membrane. There will be hyperemia, redness, engorgement of vessels, transudation of fluid, and finally hemorrhage can also occur. In rare situations, worst situations, sometimes rupture of labyrinthine vessels can occur. Too much pressure difference, too much negative pressure, rupture of the labyrinthine membranes, and vertigo, and even sensory neural hearing loss can occur. This is rarely. Generally what we see is there is retraction of tympanic membrane, hyperemia, engorgement of vessels, and transudation with hemorrhage. Hemorrhage is also quite rare. So this is what is happening inside the middle ear. I hope you have understood the pathophysiology very clearly. Now let us look into the clinical features. How does the patient present? Of course, very expected, there will be earache, terrible amount of pain in the ear. There can be hearing loss. What type of hearing loss is it? Conductive. Then there can be ringing sensation in the ear, tinnitus. And on examination, which is usually not done because it's happening mid-air in the flight, but by chance you happen to examine the patient at that time, you will see that the tympanic membrane appears retracted and congested. We have learnt about this in the pathophysiology, right? So it appears retracted and congested. And sometimes it can also get ruptured, rarely. Too much pressure, negative pressure, it draws and ruptures, especially if it is a thin tympanic membrane or if there is an atrophic scar already, there are higher chances of rupture. And the middle ear shows air bubbles. You can see air bubbles. Plus, there can be hemorrhagic effusion in the middle ear. So, these are the clinical features. And what is the treatment? Have you ever seen that when somebody in the plane complains of earache, what does the air hostess do? She brings a cup of hot water, lukewarm water, and asks the person to drink, gulp that lukewarm water. What is the basic mechanism? When you swallow, what will happen? You're trying to open the eustachian tube. If it is already locked, that is a different scenario, but until it is locked, there is still a good chance that you can open the tube. So you should do everything possible to open the eustachian tube. And how can you open the eustachian tube? By yawning, by swallowing, by doing Valsalva, all these will help. In simplest terms, you should ask the patient to eat something, swallow something, so that the tube gets opened. Next, you can use decongestant nasal drops. How will this help? I told you a pre-existing edema of the eustachian tube at the nasopharyngeal end will predispose to locking. So when you use decongestant drops, this edema is resolved and there is better chances of aeration. And finally, a myringotomy can be done. Sometimes what happens is, even after landing, even after coming into ambient pressure, the tube fails to open. Even if you do a catheterization or polyzerization, the tube might not open, and in those conditions, we do a myringotomy to ventilate the middle ear. More important than treatment in this condition is prevention. Because this is a condition happening mid-air, 5,000 feet above the ground, the patient is having earache. So your first aim will be, try not to have this condition, prevent this condition. Treatment is later on. And how will we prevent this? Number one, advise the patient to avoid flying while having a concomitant upper respiratory tract infection. Avoid flying as well as diving during upper respiratory tract infection, because that predisposes to locking of the eustachian tube. Second, during flight travel, especially during descent, the patient should be advised, not a patient, any passenger should be advised to swallow repeatedly. They can have some chewing gum or they can keep some sweets or candies. That is the reason in earlier times chocolates were distributed in the flight, so that you keep the chocolate inside the mouth and saliva is constantly secreted, and when you swallow that, the tube remains patent. So swallow repeatedly, perform Valsalva. You can have some stimulant like a sweet, candies, chewing gums. All of these help, especially during descent. And another important instruction is do not sleep during descent of the flight. Why? Because during sleep, the number of swallows will come down. That is first point. And second, in general, there is venous engorgement if the patient is sleeping in recumbent position, especially during international flights. There is venous engorgement, more predisposition to eustachian tube edema and more predisposition to locking. Plus the number of swallows will come down. So do not sleep during descent. Next, if the patient has previous history of such episodes, some intelligent patients before taking a flight travel will come to you and tell that doctor, earlier in my flight travel, during the previous travel, I had a very bad ear pain during descent. Can I do something to prevent that this time? Then what will you do is, you can see if he is having an upper respiratory tract infection. If that is there, ask the patient to try to avoid the travel during that infection until the infection is resolved. Otherwise, if there is any edema or in general also, what you can do is, when there is a previous history of such episode, give a vasoconstrictor nasal spray or some antihistamine. Basically, you are giving a decongestant, right? When you give any of these, when should you ask the patient to take this? Half an hour before descent. Depending upon the travel time, half an hour before descent, ask the patient to take any of this. This will reduce the edema, reduce the predisposition. Next, if you see that somebody is having recurrent episodes of barotrauma, in those patients, you should try to see if there is any predisposing factor, such as the patient may be having a polyp or a deviated nasal septum or some allergic history or chronic sinusitis case. In all these patients, recurrent barotrauma is possible. So we have to try to address these issues once and for all so that the patient can have a nice, pleasant air travel. So this is all about barotrauma or Aero Otitis Media. Now you must have got two doubts by now. One is, if the mechanism is so clear that it is happening because of the pressure disturbance and it is happening because the eustachian tube is not able to cope up with this rapid change in pressure, why is it not happening to every single passenger in the flight? Why is it happening only to some people? Number one, because of the predisposing factors some people have. All those people who are having that acute episode of earache might be already having some upper respiratory tract infection, or they could be having any of these features like a DNS or an allergy or a chronic sinusitis patient, or they could be having some edema of the eustachian tube. This is one reason. Second is, some people have it during some time and not during other times. Not in every flight do they have. That is because they might be running through some acute infection during that period. Now another possibility is, sometimes everybody in the flight has it. Almost 99% of the passengers are complaining of earache. That is when the cabin pressure is not adjusted properly because of some malfunction in the aeroplane mechanism. Now please understand that you are not being exposed to the absolute external environment. An aeroplane is a closed cabin. It is an airtight compartment. The pressure, the cabin pressure is maintained by the internal mechanism of the aeroplane. But sometimes it is not adjusted properly because of some malfunction somewhere, and that is when everybody in the flight will have an earache. So these are some points that you must know about Aero Otitis Media or barotrauma. It's a very interesting and important condition that some of your friends or relatives might ask you, and you should be able to explain and give some home remedy sort of tips to them. Okay, let me quickly revise this for you. What is happening? It occurs during rapid descent. Why only during descent? Because the pressure, as the altitude decreases, pressure raises, and when the external environment pressure is high and the middle ear pressure is low, negative pressure in the middle ear, all these problems will occur. This is the constant feature. Outside pressure is very high. This happens during descent. Same during underwater diving also, the outside pressure is very high, more than your middle ear pressure. Even when a patient is in a compression chamber, in a pressure chamber also, the same thing is happening. The outside ambient pressure is very high and the middle ear pressure is low. Okay, I hope you have understood the mechanism very clearly. Outside pressure is high, middle ear pressure is low. When there is negative middle ear pressure, the eustachian tube should draw air from the nasopharynx into the middle ear. For that, the tube has to be open. How can you open the tube? By swallowing, yawning, doing Valsalva and all those things. And if the critical pressure difference is more than 90 mm of Hg, then the tube gets locked. What do I mean by locked? The soft tissues will enter the lumen. They are drawn into the lumen and then it is very hard to open the tube. What happens in such scenarios? Pathophysiology, the tympanic membrane is retracted. It undergoes hyperemia, congestion, there is engorgement of vessels, transudation of fluid, hemorrhage. And in very rare cases, even rupture of the labyrinthine membranes can occur, vertigo can occur, even sensory neural hearing loss can occur. And what are the clinical features? Most important is ear pain. Although there will be some amount of hearing loss and also ringing sensation, tinnitus could be present. These are the clinical features. You will see that the tympanic membrane is retracted and the middle ear shows air bubbles. What is your treatment maneuver? You are trying your best to open the tube by any of the active mechanisms like yawning, swallowing and performing Valsalva. And if those do not work, what will you do next? You can give decongestant nasal drop, and even then if nothing works, finally we go for placing a myringotomy tube. Then prevention is more important. Avoid flying during acute episodes of upper respiratory tract infection. Keep chewing something during descent. Do not sleep during descent. And if there is any previous history, it is better to take decongestant nasal drops before, half an hour before descent. And if there is recurrent episodes of barotrauma, try to evaluate the cause and get it treated. This is about Aero Otitis Media, and I hope you also remember about Acute Necrotizing Otitis Media seen in children, rapidly destructive process caused by beta hemolytic streptococcus. And I hope you also remember about Recurrent Acute Otitis Media, more than 4 episodes per year with some predisposing factors. Try to treat the predisposing factors. So these are some other types of acute otitis media that you deserve to know. Thank you very much.